So hello, everybody, and welcome to this CMF podcast. My name's David Wheeler. I'm Professor of Kidney Medicine at University College London, and I'm a consultant nephrologist at the Royal Free Hospital. These CMF podcasts aim to keep you up to date with the latest research in cardiometabolic medicine. Today, I'm delighted to be joined by Professor Richard Donnelly. Together, we're going to be talking about 3 recent renal-focused publications. Richard.
Hello and welcome also. My name is Richard Donnelly. I'm Emeritus Professor of Medicine in the University of Nottingham, and I'm also Editor-in-Chief of Diabetes, Obesity and Metabolism. We're going to be discussing 3 publications, recent publications. All of them have a nephrology focus, but they're all relevant to many of us who practice more generalist medicine. And so I'm going to start really by looking at the first publication, which is a paper by Matsushika. And I'm going to get David to really set the context first, because this paper is all about cardiovascular risk assessment. And many people are familiar with tools like Q-risk, but in Europe, they use different tools. And so I'm going to ask David, first of all, to just set the scene about what these cardiovascular risk assessment tools are about and who they're for and how they're best used. David.
Thanks, Richard. So I think we're all familiar with these tools and perhaps, you know, our GPs use them when we go and have our blood pressure checked to predict our risk of a cardiovascular event in the following years. Now, most of these tools are based on your cholesterol level, your blood pressure, and perhaps your smoking habits and other lifestyle habits and family history. But very few of them take into account kidney disease. And we know as nephrologists that having kidney disease puts you into a much higher risk category for cardiovascular events later in life. So we've always been a little bit puzzled as nephrologists as to why these predictions, these predictive equations don't include kidney disease. And in fact, Q-risk and some of the other ones have done in the past. There have been tick boxes where you can tick CKD as a risk factor, and that compensates for the fact that the patient has kidney disease and generally increases the level of risk. But so the first paper we're going to talk about today is about cardiovascular risk scoring with and without proper markers of kidney disease, so estimated GFR and levels of albuminuria. And this comes from this group led by Joe Koresh, who run the Chronic Kidney Disease Consortium. And what they did was they looked at the European Society of Cardiology risk prevention guidelines and the algorithms that the ESC use for scoring risk, the SCORE2 and the SCORE2-OP algorithms. And they asked whether adding in markers of kidney disease, they called them add-ons, actually enhanced the accuracy of the risk scoring. So what they looked at is a population of over 3 million participants from the various data sets that the CKD Prognosis Consortium oversee. And they looked at the ESC modeling and asked whether adding in EGFR increased the predictive risk for future cardiovascular events, whether adding in EGFR and ACR, that's urinary albumin to creatinine ratio, did that in a better way, and whether the addition of EGFR and a dipsticks for proteinuria also improved the accuracy of CVD event prediction. And they used some clever statistical techniques that involved C-statistics, which help you determine whether a factor predicts an outcome or not. So they did actually improve the accuracy of the risk scoring by adding in these markers of kidney disease. And in fact, 13% of individuals were reclassified into a higher group as a result of using these kidney markers. But at the same time, 14% were reclassified into a lower group. So overall, no big change, but this did lead to reclassification of patients. And you can see the conclusion there that these CKD add-ons demonstrate better risk classification.
Okay, David, I had a couple of questions about this study. The first was, they obviously applied the renal function measures to two different populations. One was score 2, which were patients aged 40 to 69, and the other was score 2 OP for older people over the age of 70. What was the improved prediction applicable to both those age groups?
Yeah, absolutely. And it's difficult to put numbers on this, but they did improve predictive power of the equation in both of those cohorts by adding in what they call the kidney add-ons. Absolutely.
Okay. And my second question really was, could I get away with just having EGFR, or to get the better prediction, do you really need to have urinary measurements as well? How much does the urine have?
Well, as a kidney doctor, I have to say that we always like to measure kidney function in 2 dimensions, the eGFR from the blood test and the urinary albumin to creatinine ratio from the urine test. And this allows us to pick up early kidney disease from the urine albumin excretion, and also we feel is better at risk prediction. And this study actually bore that out, because if they used the add-on that had both the eGFR and the UACR, they got better predictive value for their cardiovascular endpoints. So a 2-dimensional approach with eGFR and UACR gives you the best predictive value, as nephrologists would have predicted. And
to those that are not necessarily familiar, the urinary ACR can be just measured on a spot urine sample, can it? Any time of day?
Any urine, any time of day, as long as it's from the right patient. It's not a precise tool, but it gives you a ballpark figure in terms of the amount of albumin leaking. A marker of kidney leakage, it means the glomeruli are damaged. But any urine, any time of day, just get a urine from the right patient and get that sent off to the lab.
Great, thanks. So the second study relates to some of the clinical trials around the use of finerenone in patients with high cardiovascular and renal risk. The paper was authored by Janet McGill and colleagues. It was published online in Diabetes, Obesity and Metabolism, and it tries to look at the benefits and the safety of finerenone according to different measures of glycaemic control and different aspects of diabetes care. So, for example, whether the benefits and risks were influenced at all by HbA1c or HbA1c variability. David, just give us a bit of a quick reminder and an overview about the whole finerenone clinical trial process and what the headline results of that have been.
So certainly, so it's been an exciting time in diabetic kidney disease, because we've got some new agents now that are of proven benefit. Finerenone is a 3rd generation non-steroidal mineralocorticoid receptor antagonist. So it's a drug that is in a different class to spironolactone, but effectively does what spironolactone does. Spironolactone was sort of the original MRA that we all remember from long ago. So these are 3rd generation MRAs. Finerenone is a 3rd generation MRA. This drug was used in patients with diabetic kidney disease in 2 trials, the FIDELIO and the FIGARO study. The FIDELIO study had a kidney endpoint, the FIGARO study had a cardiovascular endpoint, but both studies collected both kidney and cardiovascular data. And the 2 studies were combined into the FIDELITY database, which effectively pulls the data from both studies. So this is an analysis, as you say, asking whether any markers of the diabetes itself in these patients, remembering all these patients had had diabetes actually influenced or impacted on the benefits of the drug. So I'm not a diabetologist, but I think I do understand HbA1c at baseline. HbA1c variability, which is fluctuations in HbA1c over time, the duration of diabetes, and the use of insulin or not at baseline in these patients. And to cut a long story short, when they looked at the two studies in the FIDELITY database and looked at all these diabetic parameters, they reached the conclusion that in fact none of these parameters really influenced the beneficial effects of the drug in this population. And there's two forest plots that they present here, one looking at cardiovascular outcomes by HbA1c at baseline, by diabetes duration, and by the presence or absence of insulin use at baseline. And the important number is the P for interaction on the right-hand side of this table. And you can see that none of these P for interactions are statistically significant, meaning the results in these subsets are no different. So all the groups within the subsets here are consistent. And then the same here for kidney outcomes. Again, if you look at the p-values, although there's a bit of variability for the different subgroups, there's no statistical differences within those subgroups, meaning that none of these diabetic parameters were important in influencing the effect of the therapy on the kidney outcomes in the trial. They did, as I say, look at HbA1c variability, and interestingly found that HbA1c variability during the first year of the trial, so patients who had glycemic control, which was more likely to fluctuate in the first year of the trial, did have a higher risk of both cardiovascular and kidney events at a later stage in the trial. Now, I don't know how to interpret this. It could be those patients are just less compliant and take their medications intermittently, but it's hypothesis generating and is no doubt an observation that will be followed up in the future in future studies. So looking at diabetes progression, this is something they also looked at. This is about patients requiring more anti-diabetic medications as the study went on. No difference between those randomized to placebo and finerenone. And in the graph that they show, the lines are virtually superimposed. You can't distinguish them. So putting patients on finerenone did not delay the requirements for additional diabetic drugs. You could look at it another way. Patients on finerenone and didn't need less diabetic drugs during the trial. And so their conclusions from this post-hoc analysis of the FIDELITY database combining the FIGARO and FIDELIO trials is that the cardiorenal benefits of finerenone are present regardless of all of these diabetic parameters: HbA1c variability, HbA1c at baseline, diabetes duration, and insulin use. And some evidence from this study that glycemic variability is associated with poorer outcomes. I didn't mention safety, but they didn't find any safety concerns related to these baseline diabetes parameters in the trial.
Right. Does anything about these results surprise you, or do you think this is pretty much as you would have expected?
No great surprises to me, really. I think we're looking at a drug that is acting independently of the patient's diabetic status. We're even doing trials now of finerenone in non-diabetic chronic kidney disease. So I don't think the diabetes or any of the markers of diabetes, however you measure the diabetes, is actually important in predicting the beneficial effect of the MRA on either kidney or cardiovascular endpoints.
Great. So, I mean, it was a big database, 13,000 patients, all with type 2 diabetes, all with an EGFR above 25. There was no mention about SGLT2 inhibitor use in this population. Can you say anything about that?
Yeah, because the authors of these studies have actually released some of their data on SGLT2 use, and from memory, 4 to 5% of the patients in the FIDELIO and FIGARO studies were on SGLT2 inhibitors. And for what it's worth, in the analysis they did, the benefits of adding in the MRA are similar in those on SGLT2s and those not on SGLT2s. And actually, we've done the flip side of that from the SGLT2 studies, looking at patients who were and weren't on spironolactone. And the suggestions from the SGLT2 studies is that the SGLT2s are beneficial, whether or not your patients are on baseline MRAs or not. Now, these are small numbers of patients in big trials, and we need proper studies to look at addition of SGLT2s to MRAs. But what we've got is quite encouraging. There are additive benefits of adding an MRA onto an SGLT2 in patients who, of course, are largely already on ACEs and ARBs in all of these studies.
Okay, great. We should just move on. I'm going to talk very briefly. We're still staying with the theme of finerenone. And finerenone is obviously a drug that many people are becoming more aware of because of those big trials that David has just described. And this study by Agarwal and colleagues, published in the Journal of Hypertension, tries to provide a little bit more information about what the possible mechanism or mechanisms might be for the renoprotective effects of finerenone. And what they did here was they took what's known as the ARTS-DN study. And ARTS-DN essentially was a multi-center phase 2 randomized placebo-controlled trial in which about 800 or so patients were randomized to finerenone or placebo, and they were treated for 90 days. And this publication deals with a subgroup of that study population of about 240 patients in whom they performed ambulatory blood pressure monitoring. And they were interested in looking at the primary endpoints really of ambulatory blood pressure after 60 and 90 days relative to baseline following randomization to finerenone or placebo, of course, added on to usual care, which included a renin-angiotensin system blocker. It was interesting that baseline blood pressure was similar in the two groups, and it was around 139/78 millimeters of mercury. And they looked at both office blood pressure changes in the different dosing groups of finerenone, as well as looking at ambulatory blood pressure measurements. And office blood pressure was reduced in the finerenone 10 milligrams and 20 milligram groups by around 6 and 4 millimeters of mercury systolic, respectively. So there was a small reduction in office blood pressure in those on the higher doses of 10 and 20 milligrams. But the data for ambulatory blood pressure recording was quite interesting, and it showed bigger reductions in ambulatory systolic pressure after 60 and 90 days relative to baseline. So in the 10 milligram group, the reduction was about 8 millimeters systolic. In the 15 milligram group, it was a reduction of about 11 millimeters systolic, and 20 milligrams was about 10 millimeters systolic. And they strike me as fairly decent reductions in blood pressure, which in other studies would be associated with slower decline in EGFR. But then in the discussion and the interpretation of this study, Agarwal and colleagues seem to latch on to the fact that finerenone has a relatively short half-life. It was dosed once a day, and yet the blood pressure lowering effect, however modest, seemed to be fairly long-lasting, and it was throughout the 24-hour period. And so they jumped to the conclusion that there was no apparent relationship between the pharmacokinetics and the pharmacodynamics. But I have to say, I'm not entirely convinced that blood pressure isn't in there as a contributing mechanism in finerenone's benefit. What do you think, David?
Yeah, great question. I mean, there are reductions in blood pressure, with the MRAs, and there are reductions in blood pressure with the SGLT2s. And we know that reductions in blood pressure improve cardiovascular outcomes in the longer term. So I think it's difficult to totally exclude the possibility that reductions in blood pressure that we see with these drugs, particularly when we measure blood pressure properly, are actually in the mechanistic pathway that leads to the benefit on kidney and cardiovascular outcomes. But, it could be something else. It could be something to do with the way these drugs modulate transport pathways in the kidney. There's been a hypothesis that running patients with slightly higher blood potassium levels might have protective effects, which is, certainly a hypothesis that needs to be tested. But I think the honest answer is we don't fully understand how these drugs exert their renoprotective properties, and we need to understand how they do, because that could lead to the development of further treatments for the progression of kidney disease, in this case, in the context of diabetes.
Thank you for listening. If you want to access more information and to see the slide summaries of these key publications, please visit the website cardiometabolicforum.com and sign up to the mailing list in order to get further bits of information about recent highlighted publications. We hope you've enjoyed this podcast and discussion between David and myself. And if you have, please let us know by leaving a review on the website. So thanks for joining. And from me, goodbye.
And from David, goodbye.